we now have 3 talks from distinguished cardiologists coming. Up first is Dr. Marc Sabatine. Dr. Sabatine is a professor of medicine at Harvard Medical School and the Louis Dexter, MD, Distinguished Chair in Cardiovascular Medicine. He's a renowned physician scientist. He is the chairman of the TIMI study group, as well as the deputy editor of JAMA Cardiology. And he will give us an incredibly high-yield talk entitled Evidence-Based Management of Acute Coronary Syndromes. Please welcome Dr. Sabatine.
Great. Thank you for that kind introduction. I'm actually speaking from right outside the CCU, where I've told the team to not bother me no matter what, so I can deliver this talk. And so hopefully it will go uninterrupted. I thank everyone for spending time. So here are my disclosures. So let's level set first with this slide here as we think across the spectrum of acute coronary syndromes. What I show in the upper right-hand corner is plaque rupture. That plaque, you can see it around 4 or 5 o'clock in that cross-sectional pathology specimen from a coronary artery. And there's been plaque rupture and then superimposed thrombus that completely occludes the coronary artery. That typically then results in ST segment elevation. And I show you a snippet of a 12-lead ECG, just showing 1 lead there. And those individuals almost invariably have elevation in their cardiac biomarkers. And so they have an ST elevation myocardial infarction. On the left-hand side, I show you another pathologic specimen of a coronary artery. Here again, there's been rupture of a plaque that is sitting at around 5 or 6 o'clock. But in this case, the thrombus is subtotal and does not completely occlude the coronary artery. In this case, the patient may or may not have ST segment depression, and I show that on the snippet of the ECG immediately to the right of the pathologic specimen. They may or may not have T-wave inversions, which I don't show on this slide. They may have those changes right when they have the plaque rupture, and perhaps some superimposed vasoconstriction, but by the time they're evaluated in your office, in the emergency room, the ECG changes may have resolved. And so if you don't see ST segment elevation, but the story is consistent with an acute coronary syndrome, that puts you then in the realm of the non-ST elevation acute coronary syndromes. What I show below that with the rainbow spectrum across the triangles are then our use of cardiac biomarkers, CK&B, and really now cardiac troponin. I've tried to indicate with the longer triangle with troponin, its greater sensitivity, and in fact, its greater specificity. But if the individual has evidence of myocyte injury with elevation in the troponin in the right clinical context, then they have the diagnosis of a non-ST elevation MI. If they don't, then they have unstable angina. Just for reminder's sake, at the very bottom, I have some older nomenclature that we moved away from, Q-wave and non-Q-wave MI. The reason we moved away from that is twofold. First, as I've tried to indicate with the dotted arrows there, not every STEMI develops Q waves, and some large non-STEMIs could develop some small Q waves, so it's imperfect. But what we really care about is whether the artery is occluded or not. Q waves don't develop until hours later. If that artery is occluded, we need to act immediately. And so therefore, we segment patients on the basis of the ST segments and whether they're elevated or not on the basis of Q waves. So obviously, the history and physical remains a cornerstone of our evaluation when you're seeing someone in the emergency room or elsewhere in the hospital. Remember the cardinal symptoms of angina, substernal chest discomfort with a characteristic quality, a pressure that typically lasts for minutes. Seconds is too short. Many hours would be very atypical, so typically minutes. It's typically provoked by exertion, either physical exertion or emotional stress, and then often is relieved by rest or nitroglycerin. Patients who have all 3 of those features have what's called cardiac chest pain, or previously called typical angina. Possibly cardiac chest pain or atypical angina would be 2 of the 3 features. If they have only 0 or 1, then we call it non-cardiac chest pain. The physical exam is less helpful than we might like. Useful to be sure that the pain is not reproducible on exam. If it is, then it's musculoskeletal pain. More useful is really to look for signs of vascular disease. We can't on physical exam directly interrogate the coronary arteries, but we can auscultate the carotid arteries, the femoral arteries, feel for distal pulses. If the patient has evidence of atherosclerosis in other arterial beds, then that raises the pretest probability that the chest pain with which they're presenting is related to coronary disease. And then also look for signs of heart failure. Obviously, someone can have heart failure and not have an acute coronary syndrome. But for someone coming in with a story good for an acute coronary syndrome, and they look like they're in heart failure, that's a particularly high-risk patient. Now, the electrocardiogram, as I mentioned, is key for diagnosis. So what do we look for? As I mentioned earlier, ST segment elevation or a left bundle branch block not known to be old, meaning if we see a left bundle and we don't have clear proof that it existed previously, we assume it's new. And a new left bundle has some patients with a large anterior MI present. So much damage to the conduction system that they've developed a left bundle branch block. If we don't see ST elevations, then we look for ST depressions. As little as 0.5 millimeter are important. T-wave inversions, at least 2 millimeters. And we look to make sure it's in a coronary distribution, meaning is it in the anterior leads V1 through V4? Is it in the inferior leads 2, 3, and AVF? Is it in the high lateral leads 1 and L? Seeing ischemic changes in the same coronary distribution then greatly increases the likelihood that these are real findings. What else should we look for? Well, Q waves, they either may have developed if it's a somewhat late presentation of their MI, or it could be that they've had a prior MI, which again would up the pretest probability that the presentation with chest pain now is related to an acute coronary syndrome. Sometimes patients haven't developed Q waves, but across their anterior leads have poor R wave progression, meaning the R waves don't grow at the pace we would expect them to grow. There's a differential for that, but amongst that is a prior MI. And so then how should we look at the ECG? So 12 lead within 10 minutes of presentation, it's standard in pretty much every emergency department. Always good to try to compare to prior ECGs to look for changes, but also think about looking forward as well, meaning obtain serial ECGs. The initial one is positive in less than half of the cases. And then there's some special leads, right-sided leads if it's an inferior ST elevation MI, posterior leads if it's a persistent anterior ST depressions or concerning history. This gives you a sense here of why it's worthwhile thinking about this. And this electrocardiogram here, most people looking at this would say, and rightly so, I see anterior ST depressions in V2 and V3. I see a T-wave inversion in V1. And so I wonder that there is some ischemia, some non-total occlusion of a coronary artery in the supplying the anterior wall, the left anterior descending. But actually, it turns out for this person, then they got posterior leads. I'll draw your attention to that bottom ECG. The 3 rightmost leads are labeled V7, V8, and V9. They've wrapped the leads around the back, and now you can see ST elevation there. So this patient was actually having a true posterior MI. So this is how these special ECGs that you might keep in the back of your mind, how they work. Right-sided leads, here we're looking at the chest of the patient. You can see it's a mirror reversal of the typical position for the ECG leads, now extending across the right side of the chest. And we use this to diagnose an RV infarct in the setting of an inferior ST elevation MI. Basically, if someone has an inferior MI, the blockage could be very proximal in the right coronary artery. It could be distal right before the takeoff of the posterior descending artery. If it's proximal, that means that the blood flow to the right ventricle is being compromised in addition to the inferior surface of the left ventricle. Those patients have a worse prognosis. So in someone who comes in with inferior ST elevations, while you're activating the cath lab, you can choose to get a right-sided lead and look, and if lead V4R has elevation, that suggests the right ventricle is ischemic. that suggests that the patient is having a proximal occlusion of their RCA, and they may have a bit of a rockier course due to RV dysfunction. On the right-hand side of the slide, you see the description for posterior leads. Now we're looking at the back of a patient, and you can see those 3 leads straddling the lower tip of the scapula there. And as I indicated, we do this to diagnose a posterior MI, typically due to left circumflex occlusion. So when would we think about doing that? Well, I would say in a patient who has concerning symptoms, and either ST depressions or normal ECG. So in the example I gave, there were anterior ST depressions. If you gave that patient a nitroglycerin and the pain went away, I wouldn't worry about it. But if the pain is still persistent, it's not going away with nitroglycerin, it's not going away with a little beta blocker. Oftentimes, these are patients who the only way the pain can be relieved is by giving them morphine, basically narcotize them. When they wake up again, they say, oh, there's still an elephant sitting on their chest. And you've basically missed an MI, and they're having a posterior MI. Or if the ECG is stone cold normal, while you're working up other causes of chest pain, while you're working up pulmonary embolism and aortic dissection, there can be some MIs that are relatively subtle on a standard 12-lead ECG, and the posterior leads can bring those out. So keep that in the back of your mind if there's something a little odd with the story. Okay, so let's go to a case here. This is ruling in and ruling out an MI. And we have a 75-year-old man who presents with chest pain that lasted for 15 minutes. It started 4 hours ago. It's now resolved. ECG is without abnormalities. Think about what your high sensitivity troponin testing strategy would be. Is it A, check troponin now, and if undetectable, discharge to home? B, check troponin now and in 1 hour. If both are below the 99th percentile and no change over time, discharge to home. Or C, check now and 3 to 6 hours after symptom onset. And if both are below the 99th percentile, then discharge to home. So the correct answer is B. This gives a slightly tongue-in-cheek history of biomarkers in acute coronary syndromes. For the sake of time, I'll focus on some of the bottom rows that when troponins were introduced in the 1990s, we, up until that point, had checked CK&B Q8 hours times 3. But when troponins are introduced, we did the same thing. And people realized with their increased sensitivity that we didn't need to wait 24 hours. If someone was going to turn positive, they would turn positive earlier than that. And so more recently, the guidelines said check a troponin at presentation and then 3 to 6 hours after symptom onset. And you'll learn everything you need to learn, barring a change in symptomatology. But now with high sensitivity troponin, these assays are so sensitive that 2 things. One, that second sample can be earlier. So instead of waiting 3 to 6 hours, now you can just measure it 1 to 3 hours later. The 3 hours, really 1 hour would be fine. The 3 hours we have in there in case people present relatively early. Most people take about 2 hours to get to the hospital after they have the onset of chest pain. But if people happen to be walking on the street right outside your hospital, developed chest pain and came in, you'd probably want to wait for that second troponin for beyond 1 hour. The second important point is that you examine not only the absolute levels, but the delta or the change. The high sensitivity troponins are so sensitive that even if there is a change that doesn't bring the level above the upper limit of normal, but it's a significant delta up, those people are considered to have ruled in for an MI. So this is one way to think about troponin testing algorithm. You have chest pain. If the ECG shows ischemic changes, you've sort of made your diagnosis largely there, but you measure a high sensitivity cardiac troponin if you don't have a clear diagnosis. If it's low, and this was one of the options there, but I did not quite phrase this way. If it's less than the limit of quantification, meaning the lowest the assay can possibly detect, then some institutions would send these people out. You don't even need a serial sample. This is not the same as saying below the 99th percentile of the population. This is saying the assay thinks you gave it a sample of water, that there is absolutely no troponin whatsoever there. Those individuals have such a low likelihood of ruling in under 1% that some institutions will say one and done, and you can go. On the other hand, if it's above the upper limit of normal, in this right clinical context, you made the diagnosis of an MI. And so then they've ruled in, or there could be some other cause of myocardial injury. Most patients will fall somewhere in between. They're above the limit of quantification, but they're below the upper limit of normal. What do you do then? That's when you get your serial sample at 1 to 3 hours. If all the values are low and the delta is low, they've ruled out. You consider other diagnosis. If any of the values are high or the delta is high, then they've ruled in. And there's some cases which are sort of in between and they need additional workup, which I won't talk about today. Let's also level set in terms of terminology. And this is actually quite important on the inpatient services in the hospital, where patients are coming in with a variety of different comorbidities. Let's talk about the difference between myocardial injury versus infarction. Myocardial injury is simply defined as an elevated troponin. That's injury. That's the definition for it. Within that universe of myocardial injury is myocardial infarction. That is an elevated troponin and clinical signs or symptoms of ischemia. And that could be chest pain. It could be ECG changes, typically. It could be angiographic evidence. So not all elevated troponins are MIs. They're just myocardial injury. And so in the cardiology lingo, sometimes we'll say, oh, this person hasn't had an MI, they've had myocardial injury. Really what we mean is that they have an elevated troponin without clinical signs or symptoms of ischemia. And there's a differential for that. Decompensated heart failure, myocarditis, Takotsubo cardiomyopathy. Some are more obvious. They've just had a cardiac ablation procedure. They've just been defibrillated. It's a cardiac contusion. Some are related to right-sided strain, a PE, pulmonary hypertension. Some related to catechol surges with subarachnoid hemorrhage, critical illness. The important point is that the troponin is so sensitive now that someone who has an elevated troponin doesn't necessarily mean they're having a myocardial infarction, which typically we think is due to plaque rupture. And then we start worrying about what antiplatelet, anticoagulant therapy, should we bring them to the cath lab? If they don't have a clinical context suggestive of ischemia, then you have to think about these other etiologies, in which case the going to the cath lab may not be the right answer for them. It typically is not. In the world of MIs, then you also need to think about, is this a type 1 or type 2 MI? What do we mean by that? Type 1 MI is due to ACS, an acute coronary syndrome, plaque rupture and erosion, a change in the plaque itself. Type 2 MI also is related to myocardial oxygen supply demand imbalance, but in this case, unrelated to acute atherothrombosis. What are some examples of that? So a patient with decreased myocardial perfusion due to coronary artery spasm, or they have endocarditis and they have an embolism down their coronary artery, or they have a connective tissue disorder and they have a coronary dissection, or they're profoundly hypotensive, or they're anemic, or they have increased demand from tachycardia. So the classic example is someone who has known coronary disease, but is stable from it. Suddenly they have a massive GI bleed. They're hypotensive, they're anemic, they're tachycardic. And so there's been an increase in myocardial demand. There's been actually a decrease in myocardial oxygen supply due to the anemia. And so they can rule in for an MI, but it's not due to plaque rupture. And that person with that massive GI bleed, certainly we're not going to put them on aspirin and heparin and bring them to the cath lab. Instead, we need to treat the GI bleed and correct the profound anemia for them. So that's why this difference between type 1 and type 2 is critically important. And then there's type 3 through 5, which I won't get into. It's hard to tell the difference between type 1 and type 2. It turns out the patient profile doesn't really help you, because the patients who have type 2 MIs typically have pre-existing athero. They're just not having an acute coronary syndrome at that moment. So they're just as likely to be on the elderly side and to have diabetes and a history of smoking and hypercholesterolemia. So none of that winds up helping. The ECG also isn't helpful because they are ischemic. It's just not due to plaque rupture. So the ECG may have changes with the same sort of proportion that we see in type 1 MI. What about the biomarker levels? This is a paper that was published in JAMA Cardiology a few years ago. And really the same message in all 6 graphs here. The top panel is troponin T, the bottom panel is troponin I, and then in each of the rows, it's the troponin at presentation 1 hour and 2 hours later. The gold are the patients with the type 1 MI, and sort of the gray-blue in patients with type 2 MI. And so the type 1 MIs tend to have higher troponin levels, but there's still a fair bit of overlap. There's a fair bit of overlap. So, I would say if you see someone and their troponin is sort of super high, that makes it less likely it's a type 2. But if there's sort of a low-level elevation, this really doesn't help distinguish. And so it remains, like many things in life, a clinical diagnosis. And so if we think about acute chest pain, especially from an ED perspective, low-risk patients based on their story, ECG troponin normal, you're done. High risk, ECG changes positive troponin, we bring them to the cath lab. And then in between, and this isn't beyond the scope of this talk, but the guidelines then stratify patients on whether they do or don't have anatomically known coronary disease. And then based on that, you can decide basically to do a CT angiogram or do a stress test. Okay, so let's say, though, now we have in front of us a patient with acute coronary syndrome. How are we going to treat them? On just one slide, I'll summarize what has remained fairly standard over many years, anti-ischemic therapy, the cornerstones of which are nitrates and beta blockers. The only thing to know for beta blockers, which I've highlighted in purple there, is that they're to be given PO, not IV, and only if the patient's not in heart failure, nor should they be at risk for shock. And so this is something to keep in mind. You will see patients who have coming in with a decent-sized MI. They will have tachycardia, and there can be this reflex reaction. Tachycardia bad, increases myocardial O2 demand. I have some drugs that can treat tachycardia. They're beta blockers. Beta blocker is good for an MI. Let me push that beta blocker in that patient. But a subset of those patients will be tachycardic because they're slipping into heart failure, because the stroke volume is decreased because of this large MI, and they're compensating for a low stroke volume with a high heart rate. And now you're decreasing their inotropy, you're decreasing their heart rate, and you're going to cause them to spiral into cardiogenic shock. So think about beta blockers as a marathon, not a sprint. Great to give patients, but you want to make sure that they're either not in heart failure or shock, nor are they at high risk. And again, those would be large MIs, elderly patients, et cetera. Okay, so for STEMIs, in some way, the care there is the simplest, although they're at the highest risk because they should get immediate reperfusion therapy. It's anyone who's presented within 12 hours of symptom onset, and even those 12 to 24, we look, if you will, for any excuse to bring them typically to the cath lab, any residual symptoms, any ECG evidence. How? Typically primary PCI. Even if your hospital doesn't have a cath lab that does primary PCI, you really should have a system of transfer in place if they come to your facility and not straight to the primary PCI hospital to bring them to the cath lab. If you can't do any of that, if you can't do primary PCI, if you can't transfer them in a timely way, the times are listed there, then you should lyse the patient with the usual contraindications listed in the lawyerly font at the bottom. So here's a second case. 65-year-old man presents with a STEMI, inferior ST segment elevations, brought for immediate coronary angiography, found to have an occluded RCA. That's successfully stented, and the patient's doing well. It's also noted to have an 80% mid-LAD lesion and a 45% left circumflex lesion. What would you do at this point? A, low-level stress test before discharge. B, stent the LAD lesion during this hospitalization within 6 weeks. Or C, stent the LAD and the circumflex lesions right now. Say the correct answer is B, to go after a significant non-culprit lesion, in this case the LAD lesion. And this is the complete trial which looked at this issue. Up until the point for this trial, the teaching had been you fix the culprit and you get out of Dodge. Right? You don't want to be messing around with other coronary arteries in a STEMI patient who may have some stunning, even though you've opened the vessel, they may have some stunning to that particular wall, in this case, the inferior wall. And while you're mucking around with that LAD, if you cause any trouble there, they could then have stunning of the anterior wall and they could slip into cardiogenic shock. Well, mindset was really born when there was a high risk of complication for PCI. Now with modern stents and other modern tools, the risk is really quite low. And so in the complete trial, patients who came in with a STEMI and were found to have multi-vessel disease were randomized to get all significant lesions revased. And that was defined as any lesion with at least a 70% stenosis or an intermediate one with a high physiologic measurement, FFR, suggestive of obstruction, and FFR less than or equal to 0.80. They could be fixed within 45 days, and so it could be at that setting or later, versus just fix the culprit only. You can see in this curve here that for the risk of death or MI, that the complete revasc group did much better, 26% reduction in the risk. Something else we do for patients, once if they come in cardiogenic shock. This is the recently presented and published DanGer Shock trial. Small trial, 360 non-comatose patients come in with a STEMI and cardiogenic shock. What should we do to support them? In addition to opening up the artery, we typically will give them vasoactive drugs, dobutamine, other drugs to support them, Levophed if we have to. But should they be supported with mechanical circulatory support? We have looked at this issue with a balloon pump, which didn't show any benefit. Now this is with an Impella, which gives a better cardiac output. And you can see a lower risk for mortality, 26% lower risk with mechanical circulatory support. Now, of course, this obviously was a reduction in mortality. That's quite impressive. Not surprisingly, there was more bleeding and more limb ischemia, more renal replacement therapy with the mechanical circulatory support. But now I think this gives us nice evidence that supporting these LVs early on when they're in shock with a device is the right thing to do. Now, what about non-ST elevation ACS? This is in some ways trickier because it's not protocolized that they immediately need to go to the cath lab. So on the left, I show you the same snippet there of a coronary artery, plaque rupture, subtotal occlusion. At that point for these patients, they can get some initial medical cocktail. We'll talk about that in a little bit with antithrombotic therapy and other therapies. And then the branch point is, do you want to pursue an invasive approach, meaning all the patients go for coronary angiography, typically it's in about 48 hours or so, or a conservative or selective angiography approach. In that case, the patients continue to marinate in whatever cocktail you put them on. Then they undergo a stress test. If they flunk the stress test, or if they have recurrent angina while waiting for the stress test, then they go to the cath lab for coronary angiography. This has been, so here's an example now to try to decide what to do for this patient. 72-year-old woman, presents with chest pain that started 3 hours ago. ECG shows inferior ST segment depressions. The troponin's elevated. She's now chest pain free and the ECG has normalized. What would you do? Stress test now, stress test in 48 hours, cath immediately, cath within 24 hours, cath within 72 hours. See, the correct answer is cath within 24 hours. She just came in with an ACS, so absolutely no way you're going to put this person on a treadmill right now. You could stress her in 48 hours. She's a higher risk case. She has a troponin elevation, so she has, by definition, a non-STEMI. It's a higher risk case. You could cath her immediately, but she's chest pain free and the ECG is normalized. So there's really no mandate to cath her immediately. And therefore, we're sort of left with cathing her. And the question is the timing, which I'll get into. But given that she had troponin elevation, ECG changes, cath within 24 hours would be quite reasonable. Multiple trials have been done comparing invasive versus conservative strategy. Michelle O'Donoghue in our group nicely meta-analyzed them. Overall, invasive strategy reduces the risk of cardiac complications by about 20%. However, we like to personalize the therapy we give to our patients. This was one of those trials that we did, led by Chris Cannon in our group Tactics TIMI 18, in which overall invasive strategy reduced the risk of complications. Here, we are subsetting patients on the basis of their troponin. Patients who are troponin negative, that's the paired column on the far left, there was no benefit to going to the cath lab. The invasive approach actually had a higher rate of death MI or ACS through 30 days. In contrast, the three paired bars on the right show that for patients with a troponin elevation, then they have a very big benefit. In terms of timing, I mentioned that was another part of the question. This has also been looked at, and for the sake of time, I won't go into details for this, but basically there is a suggestion of a benefit for going to the cath lab sooner, within 24 hours, particularly for high-risk patients, those, for example, with an elevated cardiac biomarker. And so that leads us to the last time there was a full set of guideline updates, which I was a co-author on back in 2014 for non-ST elevation ACS, and these guidelines are being updated as we speak. So who should go to the cath lab? Immediately, if they have refractory angina, they have symptoms of heart failure, right? So if you have someone who you think they're coming with ACS and you can't render them pain-free, there's something weird going on. Either it's a really bad ACS, maybe it's actually a STEMI and you're missing that diagnosis. But if they're still ischemic, they need to go to the cath lab. It may be that their chest pain isn't due to ischemia, it's due to something else, in which case you need to then broaden your differential. Otherwise, if they don't have refractory angina, don't have heart failure, then you risk stratify them. And so for patients who come in with an elevated troponin, ST segment depressions, we will cath them an early invasive approach, typically within 24 hours. For patients whose ACS presentation isn't that hot, if you will, they don't have ECG changes or an elevated troponin, but they're a high-risk patient. They have diabetes, they have some mild CKD, they have a low EF, they've had a recent intervention. Those are people who typically we would cath. It doesn't need to be within 24 hours. That we might do in a couple days. And then lastly, the so-called ischemia-guided or conservative is patients who are low risk for all the features we talked about. Most recently, there was a trial presented at ESC and then published online in New England Journal. What about the elderly? This was the Señorita trial comparing invasive versus conservative therapy in about 1,500 elderly patients, mean age of 82. Overall, for CV death or MI, you can see no benefit. But I would say I look at this issue a little bit differently. First of all, Revasc was done in only about 50% of patients in the invasive arm. Why? Because they had a variety of comorbidities. In other trials, that tends to be 60 to 75%. So if you're randomizing people to an invasive approach, but you wind up not ultimately revascularizing them, there's no benefit from a diagnostic cath. And so there's no difference for CV death, nor would I expect there to be in this elderly population. There was a nominal 25% reduction in MI, which I would think would be nice to have for a patient. And not surprisingly, that for patients who were on the younger side, so under 80, then it looked like there was potentially a nice benefit, 30% risk reduction, whereas in those who were 80 or older, there's really no benefit, although the confidence intervals overlap for these 2-point estimates. So I take this that I would still, for an elderly patient, if they were high risk, they had a positive troponin, I would recommend sending them to the cath lab, certainly if they were less than 80. If they were greater than 80, I would say it's a little less clear what the benefit will be. We're not saving your life by doing this. We may be decreasing your risk of future MI, and that'd be part of shared decision-making. The other good news, going back, is that the procedural complications were low. So the notion that you can't cath these elderly people because something bad will always happen turns out to not be true. And then the same way we looked at this for STEMI with complete revasc, we've looked at this now for all MIs, and the FIRE trial contained about 2/3 non-STEMI. Same thing as we saw in other trials, that the complete revasc tend to have lower rates of death or MI. And so that's what we tend to do in patients, whether they're STEMI or non-STEMI. For non-invasive testing options, right, the patient does need to be free of ischemia for 12 to 24 hours. Testing options, if they can exercise and they have an interpretable ECG, that'd be preferred. Vasodilator if they can't exercise. And then imaging if the ECG is uninterpretable or can't exercise. And then CT angiography is obviously another option. Okay, another case here, antithrombotic therapy. 65-year-old man presents with anterior chest pain that started 2 hours ago. ECG shows anterior ST segment depressions. The troponin's elevated, gets aspirin, goes for cath, and found to have a 90% ugly ulcerated LAD lesion. Plan is for PCI. What other antiplatelet therapy should he get? Clopidogrel, prasugrel, ticagrelor, cangrelor, eptifibatide. several possible answers. I think the most reasonable ones are prasugrel or ticagrelor. That's what the guidelines would say. These are potent third-generation P2Y12 inhibitors. You could give cangrelor as well. It's quite expensive. You could give that and then transition to one of the oral drugs. You really wouldn't give clopidogrel. It's not as good as prasugrel or ticagrelor. Eptifibatide is a 2B3 inhibitor we use if there are thrombotic complications in the cath lab. Now, I could put a bit of a curveball here and say, well, the patient's actually 76 years old. The plan is for coronary angiography. We'll probably do that in the next day or so. What would you do then? Then I think the best answer is ticagrelor either now or at the time of PCI. This is getting at a couple things. One, you notice that prasugrel is not an option. That's because one, prasugrel is not indicated in more elderly individuals above 75 because of a risk of intracranial hemorrhage. Two, when we did the Triton trial of prasugrel, we did it in patients who were going to undergo PCI. Their coronary anatomy was defined. This person we don't know we're going to find. We're earlier in their hospital course. There's no indication for prasugrel. Ticagrelor was studied, given upstream, just like in this case. But subsequent trials, albeit smaller trials, have looked at the benefit of upstream therapy with either prasugrel or ticagrelor. It's not clear there's any benefit. So now we tend to wait until their coronary anatomy is defined. And this just shows the Triton platelet trials. For the sake of time, I won't go through it, nor will I go through this slide. So antiplatelet therapy acutely, start with aspirin. Almost always add a P2Y12 inhibitor. Oral agents, Ticag and prasugrel, are more potent and therefore preferred over clopidogrel because of reduction of ischemic risk. No clear benefit for starting before PCI and does increase the risk of bleeding. Cangrelor is an IV agent, fast on, fast off, can be given at the time of PCI in P2Y12 naive patients. And then sometimes we add a 2B3 inhibitor. That's something that the cath lab will do. You're not going to do that on the floor. So duration of antiplatelet therapy, this could be a talk in and of itself. It is quite complicated with a bunch of different trials giving different insights. But most patients, the answer is dual antiplatelet therapy, aspirin and a P2Y12 inhibitor for 12 months. For high ischemic risk patients, you could consider continuing it. And we and others have done trials showing about a 15 or 16% reduction in ischemic events if you continue the P2Y12 inhibitor beyond 12 months. Conversely, if they're low ischemic risk and or high bleeding risk, you should consider dropping the aspirin after 1 to 3 months. Even though we think of aspirin as foundational, that's just because it's derived from the bark of the willow tree. We happen to have that medicine first. But trials have looked at withdrawing aspirin after that time period, and patients do well. Ideally, you give them ticagrelor of high bleeding risk, then consider checking CYP2C19 genotype before clopidogrel monotherapy, because those patients are at increased risk. That's data that we showed from the Triton trial with the genetic sub-study. And if you need to stop all antiplatelet therapy, just remember, ideally you want to wait at least a month after a bare metal stent. It's very rare for us to put in bare metal stents nowadays. And 3 to 6 months after a drug-eluting stent. If you can't, and it's a high-risk stent, guidelines say you could consider bridging with cangrelor or 2B3 inhibitor. But in practice, it's not clear to me how much that really gets you. Anticoagulants, this is much faster. For invasively managed patients, typically we just give unfractionated heparin and non-estivation ACS. Conservative, either unfractionated heparin or enoxaparin would be reasonable. All right, what about triple therapy? So here we have a 72-year-old woman with a history of hypertension, diabetes, and a prior stroke. She comes in with a non-STEMI. 2 drug-eluting stents are placed in her proximal LAD. She's put on aspirin and ticagrelor. The next day, she develops atrial fibrillation. What regimen do you discharge her on? Warfarin, aspirin, and ticagrelor, a full-dose DOAC, aspirin, and clopidogrel, full-dose DOAC and clopidogrel, reduced-dose DOAC and clopidogrel. These are hard cases. The triple therapy puts patients at high risk. For that reason, I would say the most common answer would be full-dose DOAC and clopidogrel. We know that the DOACs cause less bleeding than warfarin, so the warfarin answer for sure is wrong. Of the DOAC options, reduced dose is really no data to show that you have protection from ischemic events with that, so option D isn't a good one. And so that leaves B and C. And the difference between them is dropping the aspirin or not. This was studied in a large trial, the Augustus trial, which showed that dropping aspirin significantly decreased the risk of bleeding by about 50%. with no clear increase in the risk of ischemic events. And so therefore, that's what we do. Rather than give triple therapy, we would drop the aspirin. When do you drop the aspirin? It depends a bit. I think in the trial, it was a median of 7 days after their ACS. I think if it's sort of a simple stent placement, you could drop it in that time frame when they're getting ready for discharge. More complicated PCI, more metal in the coronary arteries, you might continue the triple therapy, meaning continue the aspirin for 2 weeks or sometimes 4 weeks, and then drop. So high rates of bleeding with triple therapy. DOACs are preferred over warfarin because of less bleeding. Would not decrease the DOAC dose because may not adequately protect against stroke. In terms of antiplatelet therapy, start with DAPT, aspirin or P2Y12 inhibitor. If you're giving just clopidogrel, it's not unreasonable to check a CYP2C19 genotype. Drop the aspirin. Oftentimes it's convenient at hospital discharge, or if high ischemic risk, maybe after a month. And then in these cases, you can actually drop all the antiplatelet therapy after 6 to 12 months, depending on the bleeding risk. All right, lipid-lowering therapy. 64-year-old man presents, he's a history of a non-STEMI 2 years ago. Now comes in with another non-STEMI, drug-eluting stent placed in the LAD, 50% lesions in the RCA and the circ. The LDL cholesterol on admission, au naturel, not on any lipid-lowering therapy, was 180 milligrams per deciliter. It was appropriately started on a high-intensity stent, in this case, atorvastatin 80 milligrams daily. What else would you recommend? Target an LDL cholesterol reduction of 50% or more. Target an LDL cholesterol of 70 milligrams per deciliter or less. Add ezetimibe, add a PCSK9 inhibitor, or add ezetimibe and or a PCSK9 inhibitor to get to an LDL that's under 55 milligrams per deciliter. So think about what your answer would be. And the correct answer is add ezetimibe and or a PCSK9 inhibitor to get the LDL under 55. Their LDL is 180. You're going to put them on a high-intensity stent. That will get you about a 50% reduction. That'll get them down to 90 milligrams per deciliter, roughly. But that's not good enough. We need to get them lower, which means they need something in addition. So we know from the Prove It Timmy 22 trial that we did, that Chris Cannon and our group led, that high intensity stent is better than moderate intensity, atorva 80 better than prava 40. We then did the Improve It trial looking at adding a non-statin, in this case ezetimibe, to statin therapy. And with that, there's a further reduction in events. Small relative risk reduction, 6.4%. But a small absolute decrease in LDL cholesterol. These were very well-treated patients where even in the control arm, the LDL was 70 milligrams per deciliter. And then we showed the benefit of PCSK9 inhibitors, in this case, evolocumab, reduces LDL by 60%, decreases cardiovascular outcomes, 15% decrease in the risk for the primary endpoint, 20% for the key secondary endpoint. So in the 2019 ESC dyslipidemia guidelines, we established a new target. So previously the target had been under 70. That's what many people will remember. That came out, actually, if you go back, that came out from Prove It. After we did Prove It, the achieved LDL in the atorvastatin 80 milligram arm was under 70 milligrams per deciliter. That led to the guideline change to drop from 100 down to 70. Then we did Improve It, which achieved a target in the mid-50s. We did Fourier, which achieved a target in a median of 30 milligrams per deciliter. And so in the guidelines, we debated where to do it. It previously was at 70. We decided to drop it down to 55 or 1.4 millimoles as sort of a first reasonable initial step to improve LDL control for these patients with cardiovascular disease. But what we did put in the guidelines was to consider for patients with recurrent events, even more aggressive target of under 1 millimole per liter or 40 milligrams per deciliter. And personally, that's what I target for all secondary prevention patients. 2022 ACC expert consensus decision pathway recently came out. This is not a guideline, but sort of a preview to thinking about the guideline. And they adopted the same cut points we picked for the ESC guidelines of an LDL under 55 milligrams per deciliter. So that now needs to be your target for patients coming in with ACS. Now, practically how to do that, in Improve It, we started the ezetimibe in-house and while they came in. And so what I do when I'm attending in the CCU, like I am now, if we get an ACS case, we get a 6 STEMI that comes to us, then we put them on high-intensity stent and ezetimibe. PCSK9 inhibitor, there's a trial looking at giving it to individuals in the setting of a presentation for ACS that hasn't been studied yet. But it can be hard in the US to get approval for that. And so that may then require seeing what their LDL is. But certainly, I don't let people leave the hospital without being on a high intensity statin and ezetimibe. What about beta blockers? So for beta blockers, the teaching had always been we should have patients on beta blockers. This is from the Norwegian beta blocker trial that came out a while ago, 1981, Reagan-Bush era. 1,884 patients, 1 to 4 weeks after an acute MI. So they're stable now. So remember, I talked about at the beginning, giving high doses of beta blockers when people are coming in, that's a little dicey. These people are 1 to 4 weeks out after their acute MI. They had a 45% risk reduction in mortality with beta blockers. So beta blocker is good. More recently, a trial came out, 5,000 patients, 1 to 7 days after acute MI with a normal LVEF, beta blocker versus placebo, no benefit. So should we give up giving beta blockers to our patients? I don't think so. There's a high crossover rate. The hazard ratio in patients with a STEMI was 0.81. So I still would give it to all the STEMIs, and obviously for any patient who has a depressed LVEF. A couple other final things, ACE inhibitors, ARBs, MRAs, ACE or ARB if they can't tolerate an ACE, certainly considered for patients with systolic dysfunction, or if they have hypertension, diabetes, or stable CKD. MRAs are frequently ignored. The trial that showed the benefit, they were already on ACE, ARB, and beta blocker. Their creatinine was okay, kind of under 2 to 2.5. Their K was okay, because obviously this will cause hyperkalemia. And the indication was either they had a low EF or clinical signs or symptoms of heart failure or diabetes. So the low EF, most people think, yes, that's one of the pillars of therapy for HFrEF. But the signs or symptoms of heart failure, even if the F is okay, or diabetes, people tend to forget. It's actually a frequent board question. Lastly, what about inflammation? So here I showed 2 trials. The one on the left is a little off target. That's in patients with a chronic coronary disease, the LODOCO-2 trial. Colcott is a little more relevant on the right. That's patients within 30 days of an MI, although albeit it's not ACS. In both the trials, the addition of colchicine, sort of a simple anti-inflammatory drug that we've had available to us for quite some time, not too shabby. So 23 to 31% reductions in major adverse cardiovascular events with adding colchicine. Have we adopted this yet? We have not, in part because there are just some signals there. A signal for non-CV death in LODOCO-2, a hazard ratio of 1.51. Not so clearly seen in Colcott, non-CV death, risk ratio 1.16. It's not 1, but it certainly is not 1.5, but suggesting there could be some slight excess. And then infections, more common in Colcott in the colchicine arm, although the risk for pneumonia not clearly seen in LODOCO-2. So I'd say the jury's still out, and there'll be additional trials, one of which I think will be presented at the upcoming American Heart Association. So that should be helpful and perhaps be the tiebreaker for us. So take-home points, because I want to leave a few minutes for questions if time permits. Diagnose acute coronary syndromes using obviously history and physical, 12-lead ECG and troponin. Keep in mind, especially for patients in hospital, that can be tricky. There can be sort of quite a long delay because people are anchored to what their presenting diagnosis was. For STEMIs, we typically will do primary PCI. If you can't do that at your institution or transfer them to a facility that can, then you want to lyse them. For non-ST elevation, you got to decide whether you're going to manage them with an invasive versus a conservative strategy. And typically for people who have ruled in with a positive troponin, we tend to bring them to the cath lab. Anti-ischemic therapy, beta blockers, and nitrates. Again, remember for the beta blockers, it's a marathon, not a sprint. Select antiplatelet therapy, everyone's going to get aspirin, everyone will get a P2Y12 inhibitor. Most of those people should get ticagrelor or prasugrel. Consider the timing. Usually you can wait for the cath, and then you select an anticoagulant. That'll be on fractionated heparin for the vast majority of patients. And as you're sending them out the door, they'll certainly go out on dual antiplatelet therapy. Maybe you can drop the aspirin after 3 months. The P2Y12 inhibitor, at least 12 months. And if you're dropping the aspirin, could be indefinite. Beta blockers, which we used to consider absolutely critical, be careful upfront that they're not in shock. And then long-term, giving it to them maybe less of a mandate now, certainly if they have a low EF, certainly if they've had a STEMI. And if their pressure is good, I still typically give it. It certainly does indicate that if the patient can't tolerate it, that you're not going to be doing serious harm by withdrawing the beta blocker. LDL cholesterol control with statins plus ezetimibe and or PCSK9 inhibitor to get that LDL under 55 milligrams per deciliter. Personally, I would target under 40 milligrams per deciliter. Think about whether the patient should get an ACE inhibitor, aldosterone antagonist, and then you might consider colchicine, but most people are waiting for a little more data. All right, that's the formal end of my talk, and I'm happy to take any questions if time permits.
So excellent. As promised, that was a wonderful talk. Thank you, Dr. Sabatine. I will jump right into some questions for you. A couple of people wondering about high sensitivity troponin. How sensitive is it in renal disease? And what exactly is considered high delta?
Right. Those are good questions. So troponin and chronic kidney disease could be the talk of like an hour-long lecture. So it's complicated. Like troponin itself isn't filtered out through the kidney, but fragments of troponin can be. And so that potentially with CKD could affect concentrations. It's also tricky because patients with CKD wind up having a lot of athero, because usually you have CKD if you have diabetes or hypertension. Those are classic atherosclerotic risk factors. So it's very complicated. So someone with CKD with an elevated troponin, you treat them just like anyone else. Would not explain away the troponin by saying, oh, they have CKD. In terms of what the delta is, I was deliberately vague on that because it just depends on the assay. So each hospital will develop its own pathway for that, which is why I didn't put that on the slide. And there are some papers out there that have the thresholds, but it's really irrelevant. It's just what your institution has chosen for that.
So just to even piggyback that question, there was a question asking how robust the data might be for heart score, using that to decide who needs to be admitted versus who can be discharged from the ER.
Yeah, so those scores are certainly helpful. So I think those clinical decision pathways are actually useful and wind up usually playing a role in that sort of middle area that I perhaps glossed over too quickly on the slide. You know, if the ECG is normal and the troponins are stone cold negative, you're kind of done. And obviously, if any of those are positive, you're also kind of done because they've ruled in. In that middle ground, then, those clinical decision pathways are helpful, and those heart scores can be used to risk stratify patients. And so we at MGB have that as part of our pathway where we integrate that plus what the delta is, and based on that, it sort of determines kind of what sort of observation you would do for the person. So most hospitals are including things like the heart score and using that to come up with a standardized series of rules of who should come in, where they should be observed, and for how long.
Thank you. Wondering if you could just comment on whether or not a heparin drip would be superior to using Lovenox for anticoagulation in the setting of ACS.
Yeah, so that has also been studied by us and other people many, many times. It turns out that the low molecular weight heparin, typically enoxaparin is the one that's been studied, appears to be as good. But in the trials, if you break it down, not surprisingly, it winds up shining more in patients who are managed conservatively, because then you just have all these ups and downs with the PTT that you're sort of torturing the poor intern, keeping track of that. So for conservatively managed patients, enoxaparin would be fine. If they're going to the cath lab, then we kind of like fast on, fast off for anticoagulation. And in the cath lab, they'll get additional boluses of heparin to get the ACT similar to a PTT, but more linear at high ranges. The ACT in the lab up to the level that then is appropriate to do the intervention. So if you think the person is going to the cath lab, we wind up choosing unfractionated heparin. But if they're low risk and you think you're going to stress them in a couple days, then enoxaparin would be a very good choice.
Maybe I'll ask one more. A couple of questions sort of came in about that diagnostic uncertainty between type 2 MI, myocardial injury. Is there any role for non-invasive testing to help with the diagnosis, particularly if a cath lab is not on site?
Yeah, so it's a great question, and it's vexing, and you kind of put your nickel down, and if you think it's type 2, you're praying that the next troponin doesn't get much higher, because then you're going to feel bad that you missed the diagnosis. So these are hard cases. I think it does come down to clinical judgment. If you think they're having a type 1 MI, then barring any other serious comorbidity, you would bring them to the cath lab. If you think it's type 2, it doesn't mean they don't get a workup. So they will get a non-invasive workup. They need to be worked up for their extent of coronary disease, but it's not whisking them off to the cath lab. It's sort of treating the extra cardiac part. So the other patients, even if it's a type 2, do need some workup because their disease could have progressed. It could be now tighter now, but that may have happened chronically over time, and this extra cardiac stressor is bringing that out, but they don't need to be whisked off to the lab.
Excellent. Dr. Sabatine, thank you for a wonderful lecture, lots of clinical pearls and helpful information.
Okay, thanks for having me.
Thank you. We are going to pause for a 10-minute break, and so we will return back at 4 p.m. for update in atrial fibrillation. We'll see you then.